You may kindly rejoin the front seat, please. Thank you. Those who are sitting behind. Thank you. Honorable Minister, Dr. Ivan Butera, the Minister of State at the Ministry of Health, partners, NCD champions, distinguished guests, welcome and good morning. I welcome you to the dissemination of the second Rwanda NCD STEP survey findings and the other important NCD data. My name is Jean-Claude Mutabazi. I will be your master of ceremony today. We are gathered today for an important cause in regards to the current NCD data and in the country. The dissemination of these findings today will foster collaboration among stakeholders, will have the launch of the technical working group for the Rwanda NCD program. And with that, I would like to welcome the Dr. Francois Owinkindi, who is the head of the division manager of NCDs at Rwanda Medical Center, for his opening remarks. Thank you. You excuse me, Honorable Minister, Dr. Iva, you will provide the opening remarks for today's agenda. Thank you.
I think it's a bit very early in the morning, maybe. People are still... So I think we should just start, even though the room is empty. We're expecting people to be on time, but they were not. Good morning, distinguished guests, partners, ladies and gentlemen. Welcome to this important event, where we'll be disseminating the results of the second non-communicable diseases risk factor survey, along with some additional data on our National Cancer Registry as well as the trauma one. I'd like to appreciate everyone that contributed in generating this data and in its subsequent analysis. So today marks a pivotal moment in our health system and in the ongoing efforts to tackle the challenges that we're facing caused by NCDs. As you might know, in the last 4 years and continuously, we've been experiencing NCDs-related mortality overtaking infectious disease and maternal and child health related mortality. So it's a turning point in our health system, and I think today we'll get a bit more insight on the causes and what can be done to reverse this trend. The NCDs risk factor survey is a testament to our commitment to understanding the underlying factors contributing to the prevalence and impacts of NCDs in Rwanda. We'll go into details of the data, but we also have some positive stories that we can talk about. A quick look shows us that, for instance, the prevalence of tobacco smoking has reduced from close to 13% to 7% in 2022. And people engaged in heavy drinking have reduced from 23% 10 years ago to 15% now. Data from the National Cancer Registry and Trauma Registry further enriches our understanding of the broader health landscape in our country. These registries provide us with crucial information allowing us to identify patterns, trends, and areas of concerns related to cancer incidence and trauma case management. Breast and cervical cancer remain the top two most prevalent cancers. They represent a quota of all cancer cases that we have. But still we have an issue where the diagnosed cases of cancer are diagnosed at late stages, generally stage 3, stage 4. Sometimes they are diagnosed close to people being close to their last days. So there's one thing that cancer cases are increasing, but there's another thing that we are detecting them a little bit late. But there's been an effort in detection in terms of diagnostics deployment tools across the country, training of pathologists that are helping us also diagnosing these cases, screening at the level of community, especially for cervical cancer. They are yielding also some positive results, and we encourage everyone involved in this and to continue on this trend and to increase our efforts. On trauma, we still see that the trauma cases that we receive in our hospitals, 44% are related to accidents, traffic accidents. So we are continuing to collaborate with drive infrastructure and other partners to reduce this number of trauma-related cases, that if we don't do something now, we expect it to grow as urbanization continue. So that's why we're increasing our efforts with other partners to, again, also reverse this trend. I encourage every one of us to reflect upon the significance of our collective efforts to prevent and control NCDs and injuries. The knowledge gained from this survey and the registry data serves as a call to action to promote a healthier society. By translating these findings into targeted policies and actions, we can create a future where NCDs are prevented, diagnosed early, and managed effectively in the comfort of a patient closest to their homes to drive a positive change in our healthcare landscape. Together, we can build a healthier Rwanda. Thank you very much.
Thank you, Honorable Minister. Indeed, this gathering today will foster collaborations among partners, and we're looking forward to having, through these findings, policy development, strategic planning, and resource allocations as we look forward to working together. I now welcome Dr. Francois Uwinyindi, the Division Manager of NCDs at Rwanda Biomedical Center, to provide key findings from the 2022 NCD STEP survey. Please welcome Dr. Francois Uwinyindi.
Yeah, thank you so much, Claude. Honorable Minister of State, different partners here present, dear colleagues. Again, it's really my great honor to be standing here today, presenting the findings from our second non-communicable diseases STEP survey. But also what is most important is really how can we use this data to inform our policies, but also our plans towards improving the lives of our people. Next slide. Yes, as you can see, it's steps. I mean, we used step methodology. It's a survey that is done in 2 free steps. The first step consists of collecting information on behavioral risk factors, alcohol, tobacco, smoking, physical activity, and so on. And step 3 involved taking anthropometric measurements, body mass, height, weight, that gives us a body mass index, but also blood pressure. And then step number 3 involved, taking a biochemical, blood for biochemical measurements, mainly blood cholesterol, but also blood sugar. But also for our step survey, our second step survey, we also added some additional modules on cervical cancer, screening, injuries, but also oral health. And it's a research that we conducted, I think, from November 2021 up to January 2022. and just it covered all 30 districts of the country, and our enumerators went into 4 enumeration areas. And again, the survey the survey was done on people between 18 to 69 years old, and our sample size initially was around 6,000 people, but at the end we managed to, people that expected to respond to our questions were 5,665, and it was really a very high response rate. Next. So as you can see, the data here, so we are seeing that the majority of our respondents were females. And if you go into age distribution, the majority of our respondents were aged between 30 and 49 years old, and 44 years old, representing 42%, followed by the age range between 18 and 29 years old. Next. So let's now look at the findings from behavioral risk factors. Actually, as Honorable Minister of State has mentioned, and I think if you look at the tobacco smoking, which is one of the main risk factors for this, for major non-communicable diseases, really we can say that we have done a lot. Now the prevalence is at 7.1%, down from 13% like 9 years back. This is showing that our strategies, our interventions are really working. But if you look at if you look at maybe the distribution by provinces, again you can see that in the southern province, but also in the eastern province, that's where we do have high prevalence of tobacco smoking. And again, this is where we should be directing our interventions more. But even if we are seeing that in the city of Kigali, in the northern province, the prevalence is relatively low, but again, we should continue, teaching people, but also enforcing our different laws and regulations towards really having zero smoking in our country. Next. So if you look at alcohol consumption, this is again one of the major non-communicable diseases risk factors. So unfortunately, we are seeing an increase in the prevalence of people that are consuming alcohol. But on the other hand, we have registered a decrease in the people engaged in heavy drinking. These are the people taking, 6 or more bottles of beer on a single occasion. I think we've reduced from 23% in 2013. Thank you so much. In 2013, up to 15.2. This is encouraging because mainly because we tried also to do something on, harmful alcohol consumption. But again, as you can see, if you go into provinces, you can still see that in the western province, in northern province, still, the harmful consumption of alcohol is still high. Again, this is where we should be directing our intervention so that people can be educated and be able to consume alcohol moderately. Next. Again, the other risk factor that really we should really putting much, we should focus on going forward is healthy diet. If you look at, actually, WHO and even other institutions are recommending consuming vegetables and fruits every day, but also be able to consume 5 servings of fruits and vegetables every day. But if you look at the data we have now here, is that on average, Rwandans consume fruits, vegetables 4 days in 7 days, meaning that, we still need to increase to go up to 7 days. But if you look at, again, on if you look at the, but again, for vegetables, we are relatively good. But again, we should really increase the consumption. But if you go on fruits, really, there is still a lot of work to do. As really, very few people are consuming really fruits, in a week. So these are areas that we should really be focusing on now. Next. If you look at the servings, again, So we are really still far behind. Even if we are trying to consume vegetables, consuming fruits, but still the quantities that we are consuming are still low compared to the recommended quantities. So again, this is really an area where we should be focusing. So if you look at the fruits, we are consuming on average 0.7 servings, of fruits a day. And if you go to vegetables, it's really also almost the same. It's 1.6 servings. So I think for people who don't know really what a serving of fruits or vegetable is, it's like a serving of fruits is like 5 bananas. But those, how can we call big bananas? Or fruits that can fit in your hand, and you should eat really 5 hands of fruits. The same for vegetables. But if you look at really the quantities we are really consuming, we are really still far behind, and you should really put much effort in making sure that fruits are really available, but also somehow affordable, because this is also an issue that you should also mention here. Next. Again, if you look at really the distribution per province, we are seeing that the city of Kigali is really trying, in terms of consuming, vegetables or fruits, but still we are not yet really at the recommended levels of really having 5 servings and also consuming fruits or vegetables every day. And again, more, education, but also more efforts to making sure that really those fruits and the vegetables are really available for our people. Next. Again, another challenge that we still have is on salt consumption. Normally, it's recommended to take less than 5 grams of salt a day. But if you look at the average of salt consumption by Rwandans, it's really high. We are at 8 grams. We are at 8.8 grams a day. And even we are still really seeing people adding salt to food without even testing it. So it's becoming really one of our habits, even adding salt before even testing it. So this is also another area where we should really focus. Maybe make sure that people are really educated about the harmful use of high quantities of salt. If you look at really the distribution by province, so I think there is no difference. So it's really all around 8.5 or 9 grams of salt really that are consumed a day per each province. But again, if you look at really the distribution by sex, again there's no really a significant difference, meaning that really our intervention should really tackle all provinces, but also all population. Next. So if you look at the physical activity, this is, findings are showing that really Rwanda are generally active, are physically active. If you look at the people not engaged in a moderate physical activity as recommended, meaning that we should really be doing 150 minutes of physical activity per week. So if you look at the findings that we have now, it's showing that now only 5% of our people are not engaged in regular or moderate physical activity every day. And if you look at really the data you had 9 years back, we are seeing that we have improved. But again, here we should really take physical activity. It's not only like, sport, playing soccer or doing jogging, and the majority of these people are doing work-related physical activity, like farmers, like people that are doing, and even some of these related to transportation. So people that are transporting people on bicycles, these are people that really are engaged in physical activities. So meaning that again, so we are generally good, but again, if you look at how the distribution is in the different provinces, so the city of Kigali still, we have maybe to be more physically active compared to other provinces, maybe. So that's where we are seeing many people in offices, many people that are not probably engaged in physical activities, because people living in rural areas, they are always mobile. They are using, they're not using, taxi, buses going to their work. They are always walking. So this is also another area that we need also to focus on. Next. So if you look at the other risk factors like cervical cancer screening, like oral health, but also injuries. So if you look at the cervical cancer screening, this is also where we need to push hard. So as you know, the entire world, the global community has started the cervical cancer elimination journey, where I mean, there are really targets that have to be met. The first one is on vaccination, where 90%, at least 90% of young girls aged 15 years should be vaccinated against HPV. But also the second objective is on screening. That's really the one that we collected the information on. We are really behind. The second one, the target is to reach 70% of women between 30 and 49 years old screened for cervical cancer. But as you can see, data are showing us that we are at 11.7%. So again, this is another area that we should really put much efforts, make sure that services are available, are affordable, but also people are educated and they go and use those services, because those are targets I was talking about. They are targets for 2030. So we still have like 7 years to go. And I think if we put together all our efforts, we can reach there. Next. So on dental care, this is also another area where we should really push, we should also work on. I think people don't visit a dentist on a regular basis. Actually, regulations are saying that we should at least go to see a dentist once a year. But we go there when, I mean, we are having pain and we are no longer able to chew, so to eat. So, but if you look at really the data we have, it's showing that 77% have never visited a dentist, have never consulted. So this is really something that we need really to change. But again, if you look at the distribution across sex, you know, men should really, I mean, the high prevalence of people not consulting for dental care. I mean, the high proportion is in males. But again, the other indicator that we analyze is really we should also be able to brush our teeth using toothpaste and toothbrush at least twice a day. But as you can see, you know, it's only 19% of our people are brushing twice a day. So again, in the majority of these, we only brush in the morning. So, but in the evening or after any meal, we don't really forget. I mean, we don't remember to do that. And again, this is one of, you know, those recommendations that we should be, you know, implementing to be able to have a good oral health. Again, I mean, make sure that really people are educated, but also toothpaste, toothbrushes are really, you know, available and people are using them. Next. So the other indicator that we analyze is on use of helmet, especially for those motorcyclists, but also passengers. So again, we can see that we have improved, I mean, compared to the numbers that we had in 2013. So because people using, people not using always helmets, in 2013 they were at 74%. By now we've reduced to 30%. But again, this is also another area, I mean, continuous education, continuous law enforcement, to make sure that really people are protected. And because this is really key. And again, we have seen that there is a high prevalence of people not using always a helmet in rural areas. Again, maybe in cities, because always police is there to enforce the laws, to teach people, to tell people what to do. But in rural areas, I mean, people are not really, you know, always putting on those helmets while on motorcycles or scooters. Again, education is really key, working with different, you know, institutions, the police, but also other stakeholders. Next. So now let's look at, I mean, what we have seen is related to those behavioral risk factors. Now let's look at the, you know, the physical measurements, mainly hypertension, but also body mass index. Next. So yes, this is also another risk factor that is really very, very important in terms of, you know, diabetes, is respect for diabetes, for, you know, for high blood pressure and so on, but also heart diseases. You can see, yes, the numbers are not yet alarming, but again, we are really increasing. If you look at the prevalence of obesity, 9 years back, we were at 14%. By now, we are at 18.6%. So meaning that the numbers are really are increasing. And if you look at the targets, the global targets from WHO, we should hold the rise of obesity. But for us, it's really increasing. Again, this is another area where we should really put much efforts. But if you look at the distribution across sexes, so females are more affected. Again, this is again, another, I mean, where we should be tailoring our interventions targeting women. But if you look at the distribution across provinces, the city of Kigali, again, this is where a big issue is. It's like double of the prevalence of obesity of other provinces. If you try to disaggregate a little bit and you go into females in the city of Kigali, it goes up to 50% prevalence. So interventions in the city of Kigali should really be strengthened. Half of them have got a high blood pressure, and these are really age groups that we should be really targeting our intervention in terms of early detection, but also make sure that people are put on treatment on time. If you look at the distribution across provinces, again, the southern province, the northern province, and also the city of Kigali, that's where the prevalence looks a little bit high. But again, there is no significant difference across provinces. So, I mean, all provinces are almost equally affected. Next. But again, yes, we are seeing that the prevalence of hypertension is increasing, but again, early detection is really key. Sometimes, you know, some of these like hypertension, diabetes, of course, there are those risk factors that we can avoid. I mean, prior to delay your, but the age is also there. Meaning that we should make sure that really once we reach a certain age, now we are talking about at least 35 years old, we should be regularly screened. If you look at, there was also a question asking people if they really had their blood pressure measured before. The numbers are showing that 52% have never had their blood pressure measured before. So this is, again, where we should be directing our interventions, teaching people, but also make sure that services are closer to our population. But again, we are, if you look at the data you have, we are really seeing some improvement, as now NCD community checkup is one of our key performance indicators that we share with the Ministry of Local Government. We are seeing that the numbers are really going up. And if you look at the numbers across sex, again, males are not really measuring, are not having their blood pressure measured compared to females. So maybe males, and I think in other surveys, we do not consult health facilities, I mean, as females do. But again, we've seen that, especially for these early detection programs, I mean, community-based programs work better than really waiting people to come at their facilities. And yet these are silent killers. People don't feel any pain, any issue before before it's really late. So using really, I mean, community health workers and really other people closer to where people live, it can be a solution to this issue. Next. Yeah, we also tried to make another analysis to see how many people have really combined the risk factors, looking at tobacco smoking, looking at overweight, looking at high blood pressure, looking at physical inactivity, looking at people not eating enough fruits and vegetables. So we are seeing that at least people with 3 to 5 risk factors, the prevalence is at 7.1%. And these are really people at a very high risk of having heart attack, but also another cardiovascular event that can lead even to death. So, and again, these are the people that we should really make sure that we target them, we have them, we teach them, but also we put them on treatment on time without waiting. Next. Biochemical measurements. So, next. Diabetes. So, we also took fasting blood glucose. We've seen that really the numbers did not change a lot. So, it seems like it has been stabilized. So I think that the prevalence in 2013 was at 3.06, and now the prevalence is at 2.9. So it's really, I think, stabilized. So, and again, of course, if you look at the global prevalence, we are at 10% for diabetes. For us, it's still low. But again, we should really stop this and we should halt it and really keep it where it is. But again, if you look at the distribution across provinces, the city of Kigali, again, that's where you have many issues, as you have seen. That's where you have more people with overweight, more obese people. But so, again, it's not surprising to have more people with diabetes in the city of Kigali. Again, education, but also early detection programs should be targeting, these people living in the city of Kigali. Next. So again, this is even alarming. So we asked if people if they did, if they did blood glucose test before. We saw that 8% have never done it before. So again, it's the same for blood pressure. This is, again, make sure that people, we teach them, people get screened, and make sure that these services are friendly, but also are closer to where people live. Next. So based on the data, I think we have, based on the findings from this second NCD risk factor step survey, we crafted some recommendations that can help us to address the issues that we have seen. So the first one is, of course, on strengthening community awareness. Make sure that the community is aware, is educated about these NCD risk factors, and they can be able to change their behaviors using different strategies, but also communication mechanisms. So again, community-based services. We've started integrating NCD screening, NCD education into the package of community health workers. Again, we should really putting much effort so that to make sure that really people can get services closer to where they do live. The other one, we should also make sure that as we do awareness, as we do community early detection, we should also make sure that our healthcare system is ready to manage those people that will be identified with the disease. So strengthening our healthcare system, especially focusing on a primary healthcare level, it's really key to make sure that people can really get that adequate treatment on time, but also continuously. But also, we need to keep people treated at primary healthcare level, but you know that for some diseases like cancer, like heart diseases, we need also a specialized management. So investing also more into specialized, NCD management centers in terms of infrastructure, equipment, but also human resource is also very important to make sure that we are providing end-to-end services to our people. And again, so data systems and research. So this is also another issue. Some of these this data can be captured using different data systems, but also make sure that we strengthen the research, even to try to understand more the reason behind some of this data that we have seen. Next. Again, if you look at these risk factors, most of them they are outside the health sector. So that's why we should foster multi-sectorial collaboration. Make sure that everybody is really on board: agriculture, infrastructure, police, sports. So to make sure that really you can tackle really these risk factors into a holistic approach. Again, funding. This is also another area that you should really be working on, domestic but also external funding, to make sure that really NCD response is well resourced, and make sure that you have got resources to implement our plans and strategies. We have seen that it took like 9 years to do our second NCD risk factor step survey, and it's recommended to do it every 5 years because we didn't have enough resources. But of course, we are also suggesting how can you integrate some of these variables into regular surveys that are being conducted like DHS, so that we can maybe even be able to get some information that we need. And also, we are also exploring some more innovative ways to do it, because we can use the technology, you can use the mobile phones to be able to create information, especially on behavioral risk factors, and be able to get in real information using, fewer resources. And again, the last one, but not the least one, is really, I think you have seen that you educate the people, you try to continuously educate them, but you should also have some regulations, laws in place, especially targeting some of these risk factors like alcohol, like, unhealthy diet, like tobacco. We have seen that these are things that really will also help to tackle in a sustainable way some of these risk factors. Next. So yes, these are partners that really we work with that have supported, this second NCD risk factor survey: WHO, NABEL, the University of Rwanda, but also the National Institute of Statistics. So their contribution was really key to make sure that we have a successful second NCD risk factor survey. So thank you so much. This is what we have put together for you. It's just a summary. You have more details into those fact sheets you have, but also more information is on the in the report. Thank you so much.
Thank you so much, Dr. Francois, for this informing presentation. and quite alarming. I was looking at the findings, and I had some questions. Why do we have so many people drinking in the rural villages? Yet we have seen an increased number of bars in Kigali. So, and it's quite sad that most of the fruits that are consumed in the country, they are produced in rural areas. But yet, if you saw the data, our population in the rural areas don't consume vegetables. So as we work towards raising awareness, I think these are key items we should consider. So we are behind the clock. I'll request the next presenter to go through the presentation. And please note that we have a Q&A session after all the presentations we have. So with that, allow me to welcome Mark Hagenimana. He's the head of the cancer unit at the Rwanda Biomedical Center. He's going to present about the Rwanda cancer epidemiological profile. Welcome, Mark.
Good morning. Honorable State Minister in the Ministry of Health, representatives from different ministries, partners, stakeholders, representative from universities, distinguished invites, or protocol observed. It is my great pleasure to present the dissemination of Rwanda National Cancer Registry findings. We are going to talk about background of the registry, and we're going to present like some key results and some discussions and key recommendations that we need to take into consideration as far as cancer is concerned. Next. Yeah, cancer registry, it's an information system designed for data collection, data storage, and management. We have three kinds of cancer registries. There is a population-based cancer registry, hospital and based cancer registry. The one that you have in Rwanda is population-based cancer registry, capturing data from hospitals, laboratory, private clinics, but also data on death. Actually, in Rwanda, we had like the cancer registry at the first time in 1991, but it was local-based registry covering some data from main referral hospitals. But it is from 2018 that we have a national cancer registry capturing the entire country. The cancer registry is part of international organization. It's part of International African Cancer Registry Network, International Association for Cancer Registry, as well as International Association for Research on Cancer. At the beginning, we have been using CANREG 5, which is a WHO data collection and analysis, but I can tell you that to now, the cancer registry has been integrated into existing health surveillance system, DHS2, to ensure sustainability. Next. This is the way our cancer registry is organized. On the top, we have the director. It's the director of cancer diseases unit in myself. We have also a coordinator. We have advisory committee. Advisory committee is made by different specialists, academicians, researchers, epidemiologists from different referral hospitals, universities, and so on. There are 17. And you have also cancer registrar, one cancer registrar volunteer at RBC, but also we have focal persons who are supporting any cancer registration activities within their respective hospitals. The methodology that you are using for cancer registration, first of all, the first step is to identify cancer patients from different sources within hospitals, including patient files, paper registers, EMR systems. And then as we don't have one EMR system countrywide, those data are entered in the DHS2, which is similar to HMIS. We have an individual tracker where those data are captured. And we are using international classification of disease for oncology 3 for coding of data, so that data can meet like international standards. And a focal person from hospitals are primarily responsible of data collection, but in many cancer centers, we are sending cancer registrars to support, as you have seen that most of the time the quality of data is not good, and we send as central level cancer registrar to support data collection process within those hospitals. And after data entered in DHS2, but for analysis and advanced report, we are using a WHO tool, Canary 5 software, that is providing like advanced analysis reports such as incidence, prevalence, age standardized rate, and other advanced analysis with Canary 5 software. Okay, the main source of information for cancer registry, it includes many national referral hospitals that are having capacity of diagnosis and treatment of cancers, including King Faisal Hospital, IGIHE, Rwanda Military Hospital, King Faisal Hospital, but also Butaro Cancer Center. We are also collecting data from private hospital, clinics, and laboratories. Data also are coming from district hospital, provincial hospital, and regional referral hospital. But in order to have data on death, we are using also data from vital statistics, especially regarding data on death. I'm gonna present like key results from our National Cancer Registry. As you can see, from 27, the first year that we have at least cancer data in our cancer registry, we have registered a few cases, but you can see that over the years, the number of cases has been increased dramatically. But this is mainly due to improvement in diagnostic capacity. As you may be aware, during 27, we were having only one pathology lab and one pathologist, but as of now, we are having 5 pathology labs with 22 pathologists. But also improvement in data collection process, where we are having like a national cancer registry that is able to provide a contract data, which was not the case in previous years, as you can see in 27 and 28 and so on. You can see that in cancer according to sex and age group. The first graph is presenting cancer in male, while the second is presenting cancers in female. You can see that most of our cancer cases are diagnosed between the age of 50 and 69, which is representing 38% in male and 40% in female. Next. Looking at the top cancers that we have registered in past 5 years, from 2016 up to 2021, you can see that in males, prostate cancer is coming at the first position with 1,300 cases, followed by stomach cancer, lymphoma, liver, and colorectal cancer. Looking at female, cervical cancer is coming at the first position with 2,464, followed by breast cancer, stomach, colorectal cancer, and lymphoma. Next. Looking at the top 10 cancers that you have registered in 2020, you can see that in male, prostate cancer is still the leading cause with 387 cases, stomach 179, and liver. While in female, you have breast on the first position, followed by cervix and stomach. But you can see those data, we cannot say that those are the real number of patients that you have. It is the number of patients that have been able to reach at least our hospitals that are having capacity of diagnosis and treatment of cancers. If you compare those data with estimate from GlobalCan, you can see that in prostate cancer, for instance, even if we have registered the 367, we're expected to register 1,000 new cases. And in the breast, you can see that we only have 614, while we were expected to have more than 1,200. This shows that we are probably diagnosing a half of patients that we are expected to have. The question is, where are the other half patients? Probably some of them are still in community and diagnosed. Maybe some are poorly diagnosed by our health facilities. This is like a question that all of us should ask and try to find like an answer, and maybe try to have like different strategies of awareness, readiness of health services, so that we can make sure that all cases of cancers are timely diagnosed and managed. Looking at a distribution of cancers according to different provinces that you have, you can see that Southern Province is a province that is registering more cases of cancers, where 25% of all cancers that you have countrywide from 2016 up to 2020 are from Southern Province. And you can see that few cases are in the Northern Province. Looking at stage at diagnosis, stage, it's important to know like disease progression, but also informing treatment options as well as patient outcomes. You can see that we are still having like poor documentation or poor staging. As for all data that you have, only 33% of cases were staged. So this is mainly due to limited staging or imaging modalities, but also poor documentation of staging information by healthcare providers working in different hospitals. For the cases that at least you have been able to see that are most staged and that are most prevalent, looking at breast cancer, you can see that most of our patients are coming at late stage. You can see that 29% of breast cancer have been diagnosed in stage 4. For cervical cancer, 22 have been diagnosed in stage 4. For prostate cancer, 24 cases have been diagnosed in stage 4. And colorectal cancer and anus, it is 21%. If you take stage 4 and stage 3, and you do like the sum of those cases, you will realize that half of our patients is coming at late stage. Looking at age specific rate for most of cancers that you have, you can see the first graph, it's about the top male cancers, and the other graph is about female cancers. You can see that the graph of breast and cervical cancer show that cancers for breast and both breast and cervical cancer start at early stage, from 30 years to 25 years, but you are having more cases from 65 years and above. This shows the importance of starting screening and early detection of those services at early stage, as we are seeing those cases coming at our age. In male, you can see that we are having like the incidence of prostate cancer starting at stage at 45 years, but you can see that most of cases are observed from 65 years and above. In male and female, both in male and female, colorectal cancer also are starting at early stage at 35 years, but you're looking at the graph trend, you can see that we are having like a peak for colorectal cancers from 60 years and above. This shows the relevance of thinking our services, screening, diagnosis, and detection, not only considering adults, but also considering young adult, especially from 30 years, as you can see that most of cases that you are having, including cervical, breast, prostate, they're starting at our stage. Looking at cancer distribution in children, You can see from 0 to 15 years, you can see that the leading cause is leukemia, that is representing 19% of all childhood cancers, followed by retinoblastoma, lymphoma, renal tumors that are mainly nephroblastoma, and so on. From the data that I have presented, you can see that in 2020, the cancer incidence, the new cases that we have diagnosed and treated in our main referral and teaching hospitals represent only 53% of expected cases according to WHO estimate, with the total cases of 4,700 over 8,000 cases that we are expected to have. This highlight the importance of improving awareness for the general population, starting at community level, involving all levels, starting from community workers and other channels, improving our detection services, especially starting at primary health facility levels, but also readiness of our cancer treatment centers to be able receiving those cases are diagnosed and treat. You can see that most of cancers are starting at the age of 30 to 49 years. This shows the highest, the importance of starting like screening and detection services at our age. You can see that breast cancer and cervical cancer are the most prevalent cancers in female. This require, actually we are having a cervical cancer screening program and a breast cancer detection program, but they're not countrywide. We are having at least those programs in 19 districts, but you are working hard to scale up those services countrywide so that you can be able to screen and prevent cervical cancer, but also make like breast cancer detection. But you can see also that in male, prostate is the most prevalent cancer in male. We are not having yet an organized screening program for prostate cancer, but at least our aim is to ensure that awareness is available at all levels, starting at community level, so that at least we can identify early cases with prostate cancer, but also focusing on high-risk cases, high-risk patients to be monitored closely. While we are still planning on the good way you can start like the prostate cancer screening in our country. You can see also that you have like many cases of stomach cancer. We need to have like to strengthen our capacity of our diagnosis, but also treatment. You can see that there is a lot of number of cases that are not staged. This requires our investment to staging modalities, to increase availability of staging modalities, such as CT scan and MRI, but also our clinicians to make like mandatory staging for all records, but also good documentation so that we can use those stage information in our follow-up of our patients, but also, as we know, stage can also help in the different, for different purposes like survival studies, other research, clinical trials, and so on. You can see that among the cases that you are receiving, most of the cases, around a half are diagnosed at late stage. This underlines the importance of awareness, screening and detection, and also improvement of our diagnosis and treatment capacities within different health facilities in Rwanda. We can see that also we are having children cancers, and some of them are starting even at early stage from 0 to 4 years, especially nephroblastoma and retinoblastoma. This requires our clinicians working in different hospitals to ensure that also breast childhood cancers are not neglected, so that in the full assessment that our clinicians are doing, they can also think about childhood cancers, but also awareness in the community so that they can know that cancers are not a matter of adults. Children can also having cancers. So next, we are having like some challenges about cancer registration or cancer monitoring and evaluation in general, especially for staffing, as we are having only one staff who is also contractual staff. to support and coordinate cancer registration activities. We're having like poor documentation from patient records. There's also insufficient funding to be able making cancer M&E, a program that is working well and able to provide the regular data, but also helping our clinicians, researchers, academicians to use those data to improve cancer prevention and control in our countries. And even if we're having a cancer registry and cancer data, we have like a few researchers involved in cancer research. We are calling upon everyone to be to approach us so that we can help and we can work together, including our universities, our clinicians, our partners, and our stakeholders, so that we can make like more research in cancer. The key recommendations related to this dissemination report is to improve documentation and also to improve the cancer registry data for evidence-based decision-making, patient follow-up, and research. And we are also looking on the good way you can strengthen our collaboration and partnership nationally and internationally, but also mobilizing more funds to be able improving not only cancer M&E, but also cancer prevention and control in general. And again, to integrate also cancer screening and detection at all levels of health services provisions. Some key priority areas that this report is inspiring us. First of all, we need to increase awareness on cancer prevention and control through all channels, media, community workers, and so on. We are also planning on a good way you can scale up cervical and breast cancer screening countrywide, organize the mass screening campaign, as we have observed that organized mass screening campaign is a good way to reach more people, provide services, but also provide required investigation and treatment where needed. And also another key recommendation is to establish MDT team. Actually, we're having some MDT team in our national referral hospitals, but for sure we need also to have MDT team at the district hospital level. We need also to improve our referral pathway and patient navigation to ensure that all patients screened with suspected cancer are timely linked to diagnosis and treatment centers, and also training our primary healthcare providers, starting at health center and district hospitals, on basic cancer skills, or early detection and referral, and also integrating, strengthening human resource for cancers. Actually, we're having few specialized cancer experts. We're working hard to improve our human resources for cancer management. And also we're working with the university to see how we can strengthen cancer, or we can integrate basics of cancers in the curriculum of medicine and nursing, as well as the clinical medicine schools. We would like to acknowledge most of our partners and stakeholders that have been involved in this M&E of cancer, this cancer registry. Mostly we have like P20, having fund from NIH, have African Cancer Registry Network that is providing mostly technical support, International Association for Research on Cancer, National Association for Cancer Registries, Vital Strategies, Research and Development, PAS, ECFA, and Rwanda NCD Alliance. Thank you for your attention. This is the end of my presentation.
Thank you, Mark, for your presentation. Our next presenter is Ms. Irene Bagahirwa. Her presentation is on trauma registry data. Irene Bagahirwa is the Acting Director of Injury and Disabilities at Rwanda Biomedical Center. Please welcome.
Good morning. Thank you, Honorable Minister of State. I'm pleased to present to you the data from that we have in the trauma registry that we are implementing since 2019. The trauma registry that we have is an initiative of the WHO after sensitizing different African countries about having trauma registration in their respective countries. Those are countries that were suffering from the lack of injury-related data in their countries. So Rwanda is among those countries that started implementing the trauma registration. We started just after Ethiopia and Madagascar, and we collected the experience from those countries to be able to start our trauma registration process. The trauma registry that we have is the first multiple facility registry that was established because we were having different registries but which were based on hospitals. So the one that was putting together all the data from different hospitals was not yet started in the country. It started as a research project that we conducted in collaboration with Virginia Commonwealth University and CHUK. It was a grant called P20, and the aim was to address the target number 3.6 in SDGs, which was about cutting road traffic death by half by the year 2020. We officially launched the trauma registry in July 15th, 2019, and we started by training different data collectors and different leads from CHUK, CHUB, Rwanda Military Hospital, and the Ruhengeri Referral Hospital. It is in 2021 that we added 2 more main hospitals, Kibuye and Ruhengeri, to have a representation of the whole country. So in each province we have at least a hospital where we can have a snapshot of different injury cases in their respective hospitals. So at least in Kigali we have 2 hospitals, Rwanda Military Hospital and the CHUK, that are collecting information, but in other provinces we have only 1 hospital that is collecting injury cases in their hospitals. Generally, we have around 13,000 cases already registered in those trauma registries since August 2019 and up to September 2022. Many cases have been registered in Kigali University Teaching Hospitals. We have around 4,006 cases, while in the Rwanda Military Hospital we have 2,150. Ruhengeri Second Level Teaching Hospital, we have 2,075, and in Butare University Teaching Hospital, we have 2,676 cases already registered into the registry. In Kibungo Second Level Teaching Hospital, we have 810, while in Kibuye we have 900. Regarding the distribution of injuries by sex and age, we can see that the majority of people who get injured are male. 75% of male people are getting injured, while female are represented by 25%. Looking at the age, we have people in active their life activities from 1 to 64 years old people, who are those people between 18 and 64 years old, which are represented by 9,098%. Sorry, 9,098 people who are getting injured while they are in their active age. But we also have some quality issues, because we have people who have been registered as having 400 years old and 195 years old, which is a mistake. Looking at the mechanisms of injury, many people are getting injured due to road traffic accident. 44.3% of people are subject to road traffic accident. They are followed by falls from any height, represented by 29.1%. We also have people who are becoming injured due to human violence, represented by 11.3%. And burns, represented by 3.1%. We also have some cases due to animal bites, like those who are being hit by cows or bitten by other animals, represented by 3.0%. For the mechanism of injuries by age, we have the predominance of burns in children under 10 years old, which is 51.5%, and falls, of course, because they are children, they are playing and they are falling down and getting some injuries. But also burns is, we can say that it is not normal, but in children, most of the time, due to different conditions in our households, children can get these type of injuries. In the school age children, 10 to 19 years old, you have falls at 15.1%, and assaults, and of course road traffic accidents, because they are going to school, they are at risk of being hit by cars. We have also in the category of age between 20 and 40 years old, we have road traffic accident, which is predominant, and assaults. They are fighting each other, maybe at school or in other different activities. So that's why we have a high number of assaults among this category of age. We can also see some burns and falls. In the category of 20 to 40 years old, we have assaults and road traffic accidents. While in the category of among those people who are old, we have falls. It's obvious that people are fragile enough to have this kind of injury mechanism. We, of course, the data that we collect is kind of retrospectively collected. That's why we can see some unknown cases and missing cases, or any other issues that can be seen after the is no longer in emergency department. Looking at the injury anatomical location, we can see the body parts that are most of the time affected by injuries. The high number is on head, face, and neck, 32.5%. We also have upper extremity and hands, or lower extremities and foots, which are also affected mostly, followed by chest and thoracic injuries. We cannot ignore the intracranial injuries that we are having as well. For the conditions of injuries, we are receiving people with lacerations, wounds without being amputated, and we are also receiving those people with contusion, hematoma, and abrasion. There are some cases for crush injuries, of course, closed fracture, and others. We do assume that most of the people come to hospitals after getting pre-hospital care, just being treated for the first time on the site of it. We count those people who spent at least 24 hours in emergency unit. So we are not counting those people who are coming, get treated, and go back to their respective home. We are just collecting information for those who have been at least admitted for certain amount of hours. So we also have people who are going for intensive care unit, and others who are getting operated, and others who are being transferred to other facilities for the continuum of care. Generally, 54.7% of people, we do have 54.7% of hospital disposition after admission, of course. For those who are discharged home, are represented, after getting treated, are represented by 72.9%, and those who are transferred represent 1%. Others who are being transferred for rehabilitation purpose are represented by 0.06%. Of course, we have others who die, represented by 1.6%. For the rates of mortality in various populations and subgroups, generally, the mortality rate is 3.8%, with people who are admitted in inpatient rooms represented by 1.6%, and those who are in emergency represented by 2.7%. For pediatric cases, we have the mortality rate of 2.4%. We also have 3.9% of adults between 18 and 64, and those who are in who are aged are represented by 6.6%. The high severity score is 1.6%, and the low severity score is 3.6%. The death by injury mechanism, 49% of people die due to road traffic accidents, and others who died are respectively falls with 22.7%, blunt assault, violence, 11.9%, and burns, 5.5%. For the recommendations, we have experienced different challenges, of course, because we are collecting retrospective data, So we may experience some quality issues that we are dealing with actually. So we need to work together closely with the hospital management to make sure that the trauma registry cases that are being collected in their respective hospitals are of quality that can be used by everyone in need for improvement and the other high-level decisions. We need to scale up this registry to other health facilities. As I said, there are only in 6 main hospitals, so we need to have those registries in other hospitals. We need to continue data quality improvement. We have started already. We are conducting some quality exercise in all of these hospitals, and we need to continue with this exercise. We need to ensure trauma care improvement through trauma registry data use, and we need to strengthen the capacity of emergency staffs as well as the capacity of the hospitals to be able to treat, to provide the treatment, the quality treatment that we desire. Thank you, Honorable Minister.
Thank you so much for your presentation. Quite alarming findings. And of course, when you look at the numbers of road accidents and assault, it's really needs engagement from stakeholders to address this. I was quite earlier looking at the numbers, looking at the risk factors and trying to relate with the prevalences of different types of NCDs. And I'm sure the questions I have in mind, you also have some questions to ask the presenters. But before we proceed to the Q&A session, I would like to recognize the presence of the Rwanda National Police. And this presentation was really key to them. And please, as you address your questions, you can also address to them. Now we have entered this Q&A session. Please, if you have any question to any speaker or any relevant partner in the room, please raise your hand. You have to state what you do, and then please be brief as we are going behind the clock. So the floor is open. Raise your hand. The protocol team will provide the mic. Any question? It might be a question, it might be a recommendation. No question? We have one here. The protocol team can help us to... Can we have a mic here, please? Thank you. At the front table.
Thank you very much, presenters. My name is Dr. Julius Kamwesiga. I work with AIDS Zero Scare Foundation. I work as a medical director. My question is on oral health. Actually, it's not a question, but it's an observation. We realized that in the presentation, the number of visits taken to check on checkup of oral health is in raw numbers. My observation is to deal with the insurance companies that limit the number of visits or number of checkups with the oral health. So I think when we are dealing with this, we need to look on the side of the insurance, medical insurance especially. We can address this and we get it addressed. Otherwise, when we are remitted, and when it is taken as a cosmetic reason, then most of the times there is a limitation on the number of times we need to look at the doctors to deal with that. Thank you very much.
Thank you so much. We'll take them at once, and then we'll have our presenters to respond. So if you have more questions, please raise your hand. We have a gentleman there.
Thank you so much to all presenters. I am Edouard Ngendahayo. I'm a urologist at King Faisal Hospital. I thank you for the data shared, but I want to come to what Mark presented on the data on the cancer registry. We all know and we saw that prostate is a challenge, as breast and cervix is for females. And on your slide on key priority areas, I saw a lot of actions, and some for cervix and breast, and I saw none for the prostate. I like to tell my patients that prostate cancer is a friendly cancer, provided it is diagnosed earlier, curable with very good results. But I think there are limited efforts in awareness, diagnosis, and treatment. So I wish you put it in your priority, key priority in the near future. Thank you so much.
We have a hand from Dr. Muchumbitsi. Please bring the mic in the front.
Thank you very much. I'm Joseph Muchumbitsi from Rwanda NCD Alliance. And I wanted to ask to Dr. Francois, he mentioned the mobile phone step survey or NCD risk factor survey, but he didn't tell much about it. And I wanted to ask him if the findings were somehow comparable to the classic step survey results he presented, and also what could be the place or advantages of such a way of doing step survey for NCD risk factors. Thank you.
Thank you, Prof. We have more. Okay, let's start with the.
Yes, thank you. I'm Dr. Theopista from the World Health Organization. First, I want to commend the Ministry of Health and the Rwanda Biomedical Center and partners for conducting the STEP survey. This is very critical, as we saw that the progress has been made from the previous one, 2013. However, we still needed to do much. And more importantly, we needed to ensure that we integrate all these factors and make it in our routine systems so that we don't have to wait for the bigger surveys, which are labor and resource intensive. So we need to create awareness to the community, as it was here said, and we need also to put the resources, and partnership and collaboration with all the partners is important to ensure that we implement the recommendations so that we can register more progress in the subsequent years to come. On the cancer registry, it is very important that Rwanda has also established the cancer registry, and we saw that the most prevalent cancers are cervical, breast, prostate, and Rwanda is also embarked on the elimination program for the cervical cancer, aligned it to the global elimination plan by 2030, which is commendable. But you see that all these can be preventable and can be treated if we do screening and early detection at the early stage. So we really needed to create awareness to the communities. We need to strengthen our system as it was recommended so that we can be able to provide the early screening and diagnosis and treatment. Because we saw that most of the patients who come, they come very late. We can prevent from people from coming late, and we can be able to treat and prevent the complications which arise thereafter. Thank you very much.
Thank you so much.
And the WHO is fully committed to work with the ministry in addressing all these NCDs. Thank you.
Thank you. Thank you for recommendations. We have more questions there. Please raise your hand. Okay.
Yes. Thank you very much. My name is David Tumusimi. I'm an associate professor at the University of Rwanda. And at the same time, I'm a researcher. And having said that, I'm very happy to see such results, especially from the NCDs risk factors survey. This is very wonderful work done. And especially, I've found that the data are also concurring with some other previous surveys that have been done. So this gives a very good direction for policies and practice, and especially for researchers to continue and providing more evidence-based information. And having said that, I want to mention on the presentation that on injuries, there are some alarming data, and of which I think if the causes can be tracked, I don't know whether it is possible, maybe Madame Elaine will tell us, especially when you look at the data on insults, where we have the age bracket of 20 to 40. These are young people, but having insults, we might need to know the causes. Probably they were fighting. These are used in different places, probably fighting or school, secondary school children or universities. So I think the knowing causes also will provide a good direction for policies and where to direct the interventions. And I would recommend that the Directorate of Injuries, if it can have more activities to go further and look for the causes, that would be more helpful. Thank you very much.
Thank you so much. One more, and then we give our presenters the floor to answer. Thank you. Go ahead, please.
Thank you very much, and I take this time to appreciate the presenters and the Arabis for conducting the studies. My name's Patrice Muitend. I'm a senior health specialist at World Bank. I was looking at the data, how they have been reported, and I understand that more is involved in understanding the challenges of NCDs and the risk factors. And I would like to know if more parameters have been considered when collecting the information, such as socioeconomic status, professional categories of respondents. For instance, when you look at heavy drinking, we'd like to know who are the heavy drinkers: jobless, employed. If are employed, are they employed in the formal sector or informal sector? This would help design and implement communication strategies which are targeted to different kind of people, and design and implement work-related policies to discourage heavy drink among, for instance, employers, employees, because this will affect the productivity. And with respect to physical inactivities, this would also help design workplace-related policies to encourage and promote physical activities at workplace. Thank you.
Thank you so much. Important question indeed. I think this one is addressed to Dr. Francois. So now we have 4 questions, and I would like to start with Mark. There was a question addressed to you on prostate cancer. Okay, go ahead.
Thank you for the question. Okay. Yeah, so as we have presented key findings from cancer registry, so you have seen that prostate cancer is the leading cause of cancers in males. And according to the question asked, it's how can we prioritize also prostate cancer as it is a leading cause of cancer in male, as we are prioritizing cervical and breast cancer in female. Yeah, for sure we have started with some cancers that we can have like key interventions that can even help to get outcomes. As you all know, cervical cancer, it's a cancer that can be easily prevented and eliminated. And we are working hardly to achieve global strategy of cervical cancer elimination by 2030. But also, you know that breast cancer is also a cancer that can be detected. But those are, even if we have started on those, we're not putting behind prostate cancer. For prostate cancer, we don't yet have like organized screening for prostate cancer. Most of evidence-based findings are when you don't have like enough resources for diagnosis, treatment, specialists, and so on. And you know that most of cases of prostate cancer are diagnosed at early age and can be have like a silence and not killing more patients. But for sure, it is also a priority, even if we don't have like organized screening. Our key priority that we are doing for prostate cancer is awareness. At least people at community level, they can be aware of the disease. That's first. Second are diagnosis, so they can go to health facility anytime they have any symptom. And also focusing for risk people, at least those who are having like some risk factors. We are recommending to have like a regular checkup within health facilities, but also we are planning to implement like the screening of prostate cancer step by step. It is not easy to make it countrywide at the same time, but we are mostly focusing on awareness, detection, proper diagnosis, proper management, while still organizing like step by step also organized screening for prostate cancer. Thank you.
Thank you, Mark. Before we leave that table, there was a question addressed to Ms. Bagahirwa about how to track the causes of most of the findings on trauma and injuries.
Thank you. I just want to thank Professor David for this good question. It's like not a question, it is a recommendation. So we can conduct kind of assessment to know the causes, household assessment or school-based assessment to know the causes. So thank you for the recommendation.
Thank you. There was another recommendation from on how to incorporate oral services into insurance schemes. I don't know if anyone in the room can make a comment on that. Anyone? Okay, we can proceed to a question addressed to Dr. Francois from the World Bank about the socio-economic and other parameters when conducting this survey.
Yeah, thank you so much. If I may also go back to the question on prostate cancer. Actually, we did not forget prostate cancer. And of course, yes, the focus now is on breast and cervix because these are, it's easy to screen, it's easy to prevent, but also better treatment outcomes when they are diagnosed at early stage. But also as, it's an ongoing process, especially trying to include even additional services, additional cancer services on medical insurance schemes, especially the community-based health insurance. I think it's something that is ongoing, and also prostate cancer is one of those priority cancers that we have, that should be, included. But also, let's say if you look at the recommended screening strategies like PSA, so we are trying to integrate, PSA into other, the testing capacity is available. Recently, we acquired point of care machines that we're using for lipid profile, that we're using for A1C, but also those machines are also doing PSA. So it's a matter of integrating, and also these are tests that will be easily available at the district hospital level, even sometimes at the deaf centers. It's a matter of training people on how to interpret, but also have a quick referral, working with the Society of Urologists, doing mentorship, and really be able now to have that early identification, but also timely management. So I think it's really something that is also, in our plans. On top of that, there's also colorectal cancer screening. There also easy tests to do that can be done at primary health care level, but also, again, as Mark was saying, we should also have follow-up tests to make sure that the diagnosis is confirmed. But again, these are things that I think are in the pipeline, and very soon we should start doing that, working again with, our health insurance companies. There was a question from Patrice asking if we did some analysis based on economic status for some of these risk factors, but also job and jobless, especially physical activity at the workplace. Exactly. And I think, yes, we presented it's like a snapshot, but we have more detailed information into the report, because we quoted information on socioeconomic status, we quoted information on these other variables, just you can do that analysis. But if you can see, of course, physical activity is zero in people working in offices. This is I think, one of the findings. So again, recently we also launched the program on wellness program at workplace, and NCD prevention, NCD screening, but also mental health, interventions are now being prioritized at workplace, using now those OSH committees at different institutions. And I think this is also something that will help us to address these major risk factors at workplaces. There was also a question from Professor Muchumbitsi on mobile phone survey on non-communicable risk factors. Exactly, this is one of the ways that we can use to have a quick data using fewer resources. We conducted one recently, and we have seen on some risk factors like tobacco, smoking, it's almost the same as the prevalence that we have. I think from our MPS, the prevalence is 7.6%. It's almost the same as 7.1. And if you look at the alcohol consumption, yes, we are around 45%. It's really almost the same. So we have seen that at least for step one, we have now an alternative using mobile phone survey to get quick information, not really waiting for 10 or 5 years. We can really easily every year, even every 2 years, get information on those behavioral risk factors, and then maybe wait for 5 years to go now and do those anthropometric measurements, but also biochemical measurements. So this is really one of the alternative ways to get quick information. Thank you.
Thank you so much, Doctor. Yes, the presentation we had here, there were key findings, but I'm pretty sure in the report that is going to be presented to you, we can find more. Was talking about the linkage of risk factors and parameters used. It can be maybe less enforcement of regulations, or maybe the socio-economic status of the population. So everything will be in the report, and we thank our presenters for the wonderful job they did. And since maybe you have seated for long, and in the other room they had noticed, maybe that's why they are giving us a glimpse of the transitional dances there. So we are going to a short health break. We're going to take 15 minutes. After the health break, we'll come back here for a panel discussion. Once again, a round of applause for our presenters this morning. And please enjoy your break. Thank you. Kindly regain your seats. We are about to resume our program. The protocol team, can we have everyone back in the room? Thank you. Kindly take your seats. I hope you enjoyed your break. I heard some people were complaining about the shortage of vegetables. But I really like the way it is noted on the agenda. It's a health break, even moving around. Consider that we have been sitting for a long time. It's really satisfying. Ladies and gentlemen, we are going to proceed on the next item on the agenda, which is a panel discussion. This panel discussion will be moderated by Mrs. Julie Piotimaeva. She is a pharmacist and a program assistant at Rwanda NCDA Alliance. I will welcome her on the stage. She will introduce her panelists. Please welcome Miss Julie on the stage.
Good morning, everyone. We are coming back from the healthy break. Can I please hear something louder? Good morning, everybody. Aha, it's coming. Good morning, everyone. Everybody speaking French in the room, bonjour. Ah, this is louder. Hi, everybody. My name is Julie. I'm a pharmacist, and I'm as well as the program assistant at Rwanda NCD Alliance, and I'm really delighted to be the one moderating this session. Please, would you turn to your neighbor and tell him that we have data for evidence-based action? I'm not hearing you guys. Please tell them that we have data for evidence-based action. Yeah? So please identify your role. Yes? Thank you. I'm going to be welcoming on stage our different panelists. The first one is going to be Dr. Albert Tuyishime. He's a medical director. He also holds a master's degree in clinical epidemiology from the University of Rwanda. He serves as the head of HIV/AIDS, disease prevention and control department at the Rwanda Biomedical Center. You are so much welcome. Please, will you clap for him as he walks on the stage? The second one is going to be Professor Mchumbitsi. He's a medical doctor. He's also the chief consultant, pediatrician, and cardiologist at the King Faisal Hospital, but he's also the president of the East Africa NCD Alliance, as well as the chairperson of the Rwanda NCD Alliance. Please clap for him as he walks on the stage. The final one that I'm going to call is Dr. Gatera Augustin. He's a medical doctor by background and senior public health officer with more than 15 years of apologies for that, 15 years of experience in public health interventions at the World Health Organization. Please clap for him as he walks on the stage. Apologies for we do not have a representative from the Minaloc as they are currently absent. But I'm expecting you guys to be engaging. Yes? Do we all agree? Yes, I'm expecting all you guys to be engaging as well as to be participate in this panel as now we are moving from the data to something that is actionable. Do we agree on that? Thank you so much. All right. As I said earlier, we are moving from the paper and the findings from something to something that is, all right, to something that is actionable. So the first disclaimer that I'm going to make is that let's not have answers that are political, but let's have answers that are actionable. Yes? Do we agree?
Yes. We agree.
Thank you so much. I'm going to start with Dr. Albert. We look at the data, and you know, we at least we have foundation or we have basis of comparison. When you look at the data of 2013 and you look at the data of today, how can we explain the difference of numbers? One of the things that highlighted or caught my attention when I was going through the booklet, it's the difference, for example, when you look at alcohol. You see the people drinking alcohol has increased, but the people drinking alcohol heavily has decreased. So we have more people drinking alcohol, but more people drinking alcohol responsibly, which is weird. But anyway, when you compare both data, what challenges can you talk about in the implementation of NCD program in the country? Thank you.
Good. Thank you very much. And I promise to not give political answers.
Thank you so much.
So you are right. As we've seen, if you look at the findings from 2013 and you compare with what we just got, we have some good stories. Mm-hmm. You can look at the tobacco smoking, which has decreased. You can look at people engaging in physical activity, which is increasing. So something has been really positive has been done. But again, on the other side of the coin, we have where we had a decrease or increase in bad habits or increase in bad risks. Mm-hmm. You can talk about people engaging in alcohol consumption. You looked at the obesity, overweight, blood pressure. So that calls to all of us
Yeah.
to engage more or to put more effort in terms of educating people, because one of the key elements in this area of non-communicable diseases, they are really linked to individual behavior or choices,
Yes.
but also we have in a component of societal or cultural pushes, if I can put it that way. So I would say whatever we've got here, it's a result of combined comprehensive efforts, starting from the awareness at individual level, but also at a community level. It's a result from specific campaigns we've been having. We can talk about education we've been conducting. We can talk about specific campaigns, starting from specific cancers, but also talking about risk factors. It's also a result from health education and promotion. Everyone here knows what we've been doing jointly with our stakeholders. We recently we kicked off workplace-based well-being, which is going to help us again keep pushing on reducing these risk factors. But also, I would say it's a result from partnerships. You shouldn't expect the Ministry of Health alone really pushing and having this kind of results in 8 to 9 years. It's not possible. But due to effort from everyone here in the room, but also the community itself, that's how we can expect to have this. I wouldn't stop there. Despite those efforts we've put in place, we had a lot of challenges.
Yeah.
I don't know if I can pause here and we come back to challenges.
Please,
or
actually, yeah, elaborate on the challenges.
Yes, please. So, as I said, some of the challenges, they are really linked to individual behavior. You would really teach someone to stop smoking or to stop heavy drinking, but at the end of the time, it's all about him or her to make that decision and stop actually. So it's really one of the challenge. It has to be a continuous exercise or effort to keep educating people. The second point you raised was cultural or societal pushes. We've been looking at different numbers in terms of alcohol consumption and heavy drinking, and we have different levels per province. So one should dig deep and understand why do we have heavy drinking in this part of the country. We should even be able to go up to the sector level, even household level, because it's well known in a household where parents are drinking, kids, they have high chances or likelihood of also drink. So that was also part of the challenges. And lastly, I would talk about resources we're investing in this program. If you look at it, it's one of the most expensive programs from the prevention, treatment, and rehabilitation.
Yes.
So if it is the most expensive, we should be having more resources injected in this program. So we are not yet there, and it's one of the challenges we've been having.
Thank you so much. Thank you. One of the things that I'm echoing is how the individual choices are literally the ones that are contributing to the global or to all the efforts that are to achieve these results. Going to WHO, Dr. Augustin, we have data. We know that WHO is the World Health Organization, that you guys work in quite a very wide range of countries. So at your level, how would you compare? We have data now that is in Rwanda. How would you compare the data that is the perspective, NCD's perspective in the country compared to the NCD situation happening in other countries?
Thank you very much, moderator. The country data is a property of that country.
Yeah.
And it depends on the strategic and the approach on a specific program, including the non-communicable diseases.
Mm-hmm.
So if you ask me today to compare what Rwanda has achieved towards fighting against NCDs or doing promotion for protection, for prevention and the control of NCDs, it will be quite not similar to other countries because each country has a specific direction toward this fighting against NCDs. So I will be able to express in context of Rwanda because I'm Rwandan, although I'm working with the WHO, but still we do our works together. So I will concentrate more on the Rwandan data. So, but again, before I reach on that, you asked me about the prevalence of NCDs globally, yeah. And that can be compared to the prevalence in Rwanda. Actually, if it was a dashboard that indicating the increase of prevalence in Rwanda and indicating the prevalence of increase in prevalence of non-communicable diseases globally, on globally, it will be an alarming. If it's a dashboard that indicating yellow, green, and the red, I would say it will be on the red and the dimming. Actually, it's alarming. Where in 2 seconds, one person is dying prematurely from NCD globally. And about 41 million people are recorded dead due to premature death due to NCDs. So this is a big loss of the population that needs a special attention for the intervention. Among that, 17 million people die from NCDs before 70 years. So you see the whole population from 30 years to the 70 years, we lose a lot of people through NCDs. And among that, 86% of those occurs in the low and the middle countries. The leading cause, as they have mentioned, as the stepwise survey has indicated, is the cardiovascular disease globally, which is killing 17.9 million people per year, followed by the cancers, which almost take like 9.3 million people per year. This is a big loss, followed by cardiovascular diseases, chronic respiratory diseases, and the diabetes. This is a very big shot globally. And of these 4 groups of disease, which are concerned for the NCDs, 80% of all are recorded to be killing people before their age or probable age of dying. Associated risks, we have seen them, and that's why actually we are here to see the progress and to do surveillance for the risky factors which always are exposed to non-communicable diseases. Of course, there are so many factors which has increased and they came in to facilitate the increase and the increase of number of people with NCDs. There is unprecedented urbanization where we have a property plan. There is a shift of population from the rural area to the urban, as well as in the urban, we don't have an appropriate way of, attacking the pollution condition that you are living in. Also, there is industrialization in the city that doesn't go with appropriate plan and the allocation of the people where they live, you find some industries. So all of this contributes to the air pollution, which inherited by this population, and this is the main cause of the people suffering for NCDs. The second global and increasing prevalences of NCDs globally. So back to your question in Rwanda. Rwanda has set so many interventions against NCDs. as a WHO, we work very closely to the government to assist and accelerate all the protocols, all the strategies, all the plans they have made to make sure that we are combating all these risk factors. There are so many measures which have been, I think on that.
Thank you so much. Staying on that, staying on what you just said.
WHO is always along with the government in the planning. Where we are today, based on this evidence which is findings, are the evidences that should be based on the planning. So in planning and implementation, improving where we are, and trying to find how the best way to reach our objectives according to the set objective. WHO is always along the government to implement that. Thank you.
All right. I believe that was kind of political, but we will, it's okay, we will take it. I'm coming back to you, Dr. Albert, just to supplement on what he said. He mentioned how WHO works a lot alongside with the government, and literally you are the government here represented. What do you think can be done different to ensure that these results remain consistent? We have seen a very good decrease in the tobacco use, but then we don't want to see only tobacco going down. We want to see alcohol, we want to see diet, people eating better. So what do you think you guys, as the government institution working with WHO, can do different to make sure that this fight is consistent?
Thank you very much. I think we all know impactful interventions when it comes to fight or to try to reduce one of these risk factors. But the added value of what we are seeing now during this dissemination is that we need to keep implementing those impactful interventions, but in a targeted manner.
Okay.
Because I can pick one example. If you remember, the southern province is the one having the highest prevalence of heavy drinking. At the same time, the same province is having the highest prevalence in terms of tobacco smoking. At the same time, if I remember well the numbers, it is the first one with the increased blood pressure.
Yeah.
The three, they do talk to each other, which means, yes, we keep educating people on reducing these risk factors countrywide, but we need to pay a special attention to that specific area. So to me, that's the main element I'm taking from these findings. Yes, we know impactful interventions. Let's now try to be more targeted.
Yes.
And then
one of the aspects that these data are echoing is the need for multi-sectoral collaboration, multi-sectoral coordination on the fight against NCDs. And even Dr. Albert mentioned earlier how these findings is a result of combined comprehensive effort. So as the chairperson of Rwanda NCD Alliance, first of all, what is Rwanda NCD Alliance? What does Rwanda NCD Alliance do? And secondly, what are the current interventions that are being implemented in the community by Rwanda NCD Alliance to support the government in the fight against NCDs? Thank you so much.
Thank you very much. First of all, I would like to thank the organizers for having civil society having a seat in this discussion, because we represent, Rwanda NCD Alliance has more than 25 member organizations, civil society organizations, fighting NCDs, mainly groups of people living with NCDs, have people living with diabetes, with cardiovascular diseases, with stroke, survivors of stroke. So different NCDs, people living with different NCDs have groups, associations, usually quite small. And, but we have also the youth-led organizations, which are member, including students from different medical school, pharmacy, and different health-related universities, and all together have been working with the different stakeholders. So we have opted for active and participative advocacy. Don't just go on the street to contest. We go on the street, we go to see stakeholders to work together to curb the NCDs burden. And if I can mention some of the initiatives or the main actions we are conducting, let me mention maybe our role in the Car-Free Day initiative, which is not only about mass sports, but which is also about NCD risk factor screening and education, which is quite an original combination. So we have seen that since 2016, when we started with the city of Kigali, we have been in charge of screening for risk factors, and actually the numbers we have been finding are quite in accordance with the results presented today. So meaning that not only we screen, but also we educate. Every person coming to do sports, we go back home with a brochure showing not only his results, but also some key tips on healthy lifestyle. The other initiative I can mention is that we don't only, we are also involved in mass education or awareness raising through the different media, through our platforms on YouTube, on national TV, on different radios, because actually we did a situation analysis in 2021 on the situation of NCD policies in the country. And we saw that the country has all needed policies and programs. But one of the weaknesses we noticed was about quite low level of awareness, not only in the community, but also at the level of even leadership. Yeah. So there is a need to raise awareness at all levels. And majority of our population do not have a TV. So we should go down to using the radio because it is the most accessible. And I have to say we don't do it enough, but one of our dreams is to have a continuous program on radios to educate and raise awareness about NCDs. Because, and using champions, people living with NCDs, because they are the ones to know. And we have been collecting videos, testimonies from our different groups of people living with NCDs. And we have put together a national advocacy agenda, which we handed over to the Ministry of Health in our first national NCD conference to show the questions and asks of people living with NCDs. Because we need to amplify the voices of people living with NCDs. And one of the key asks was universal health coverage, access to care. Saying that even if we have one of the best insurance systems in the region, there is still some hardship for people living with the most chronic diseases to access care. I've been talking about cancer, but when you are diagnosed with a cancer and you need to go for treatment, the 10% copay can be so much money that no one can afford, even people who are considered to be rich. We have noticed that through the other initiative we have been involved in, which is screening for breast and cervical cancer in the Kicukiro district, where we have also following the patients who have been, the people who have been identified, so to make sure that we accompany them and they have access to diagnosis and treatment. And we have seen that illiterate people, you tell them you have a cancer, they be so afraid of the cost of any treatment that they may not even go. If you don't follow up on them and make sure that you guide them, you take them to, you facilitate transport. It is not even that much money, but it is something which is needed. So we have a patient's navigator who is following them from the district, from the ground to the health centers and the treatment area. So not only awareness, but also trying to support people to have access to care. And we should, that poses the question of financing. We know the country is doing its best, but how much, what is the percentage of funds allocated to health, which is allocated to NCDs? I think it is less than 2%. So how can we improve that? We have been suggesting different solutions, or at least way of trying to do that, including, we know that the government is trying everything to make sure that the community-based insurance is supported by different resources. But we have been saying that there are still some taxes, health taxes of unhealthy commodities and products, which could be eventually increased, but also which, with earmarking part of that income to support NCD management, prevention and management. It has been done in different countries efficiently. It has been shown. It is recommended by WHO, but we need, I think that's an area, seeing those findings where we could make more efforts, as well as in the field of regulations. How could we regulate alcohol? Alcohol consumption, alcohol production, alcohol distribution. Why don't we have a task force to discuss about this? Just with all the stakeholders, discuss about how to reduce harmful use of alcohol, harmful use of tobacco. Yes, it seems tobacco has decreased, consumption has decreased, but is it low enough? I don't think so. So I think all these findings should inspire all of us, all stakeholders, to work more. And for me, for us, one of the proposals also is to have a formal multi-sectoral coordination committee. WHO recommends a high-level multi-sectoral coordination committee. And we have been proposing that it should sit at the Prime Minister's office so that different involved ministers can talk to each other and sit like we are sitting here to discuss about these results, to discuss about the policies and the solutions to tackle these issues. We are continuing that advocacy. The technical working group on NCDs is the other somehow multi-sectoral mechanism to continue tackling prevention and control of NCDs. It is on its way. I think it will be launched today, which is we really applaud on this initiative. I would say that I have very much liked one of the recommendations of Dr. Francois, saying we should integrate NCD screening in the daily routine healthcare approach. He talked about the regulations as well. He talked about the domestic investment, the multi-sectoral coordination, So all ingredients are there for us to improve, and civil society is ready to play its role at all levels in terms of expertise eventually, but also not forgetting the voice of people living in NCDs. We find that they should have a seat at the sectoral and technical working group, which is the case somehow through the different patients' organization, but also at the policy making and the political management of NCDs. If I could say, we have a representative of disabled people in the parliament. Why not have a
with NCDs, and we believe that who else is better to educate about a condition than somebody who is living with a condition. So it's really important. The second one is alternative financing for NCDs. That is, earmarking, increasing the taxes on some of the unhealthy commodities so that that increase on taxes could be earmarked to NCD programs in the country. So like you said, we have quite a number of policies that are written, but we still need to move from what is written to actually what can be literally implemented in the community. I'm going to pause here and hear from you. At the beginning of this panel, we agreed that it's going to be engaging and participatory. So I would like to request if there is any question for any of our panelists in the room. Kindly raise your hand so that we can give you a microphone. We have we do have a question. I'm counting 1, 2, 3. Any other question? All right, let's start with those 3 ones. Please, because of time, make your question direct and brief. Thank you so much.
Thank you very much for the good panel discussion. And I really appreciate the presentation since the morning. And I appreciate more the multi-sectoral collaboration that have been highlighted by many of the presenters, even the panelists. And we have been claiming that these NCDs has to be presented by going to the change of behavior of the individual. But then I have a question. Do we have enough options for those individuals to choose what's light or what is long? And this question takes me to, as well back to multi-sectoral collaboration. I want to ask about One Health approach that are in place in Rwanda for addressing NCDs. Before continuing to that question, I'm Vivian Muhire. The reason I'm so interested in One Health is because I'm pursuing One Health at University of Global Health Equity, and I have seen that we are missing that part in NCDs, control and prevention. My question is asking, how are we engaging ministry in charge of animal and crop management, if I can call it, maybe it's Minagri. And we always talk about consumption of animal food, animal-based food, but then we don't go further for looking for the regulations for genetic modified organisms that are used, which are found to be the risk factor of many cancers and also as well hypertension. The same to agriculture. We are using fertilizer, we are using pesticide, but then we are sitting and claiming that individuals are the one to choose, but then they are using those fertilizers. Of course, it's good that we are fighting food insecurity in the country, but as NCD advocates, we need to engage those people in safe use of those pesticides, and also have regulations, maybe in FDA or any other organization that test the pesticide, and also balance the benefit we are going to get from the use of those pesticides and the NCDs that can raise from the use of that pesticide, for us to have that evidence-based action, as you mentioned, Ari. The same to...
You have another question?
No, I'm still on One Health. Now I'm tackling animal part. I'm going to environmental part. We are talking about climate change is the risk factor of many NCDs, but then are we having resources for allowing the community to use safe energy, clean energy? Are we encouraging them to plant a tree as needed? And the same for human health. We have moved forward and we have a lot in human health, but...
Comment of RBC representative Albert that said that one of the main challenges that we are facing when tackling NCDs risk factors are social and cultural pushes. So I want to tell you that the good news is that those social and cultural pushes can be modifiable when you early tackle and target to educate young ones, young people early. When they are early educated, they can grow up with those fresh minds that you fed them, and you did it before they are deeply corrupted with those social pushes. So our interventions, I suggest to be tackling those young ones. Like, for example, we've seen a very good decrease in heavy drinking of alcohol, but a rise in consumers. That means that we are very successful to tell those people who are already consumers to drink responsibly. But who are those new ones that are joining them? Obviously, young ones. So I suggest to put much effort, our interventions to those young people in tackling NCDs with factors. My second comment...
Thank you so much. Because of time, I'm going to cut you. I am so sorry.
1 minute.
I am so sorry.
Okay.
I have to take somebody else. Thank you so much.
Thank you so much.
I'll continue from what he said. Because we're together, we're advocating for the same thing. So from what he said, we have seen some interventions from the Africa CDC responding to COVID-19 vaccination, such as the AU Bingwa. So we've been working with Rwanda NCDs Alliance, but I want to hear from a perspective of RBC and WHO. What initiatives are we taking in engaging youth to tackle the youth program? Because we know cancer is a progressive disease, though it affects the older generation. It starts in the early years, in 20s. So I think it would be more sustainable if youth respond to youth from all policy design, implementation, and all stuff. So what do you think? Thank you.
Thank you so much. Do we have another question? We are done. All right. Coming back to our panelists, I believe we can start with answering the last one. What initiatives or what are some of the activities that are currently being done by both RBC and WHO to involve or to engage youth in the fight against NCDs? Any of you can take that.
Yes.
Let me start with you, actually, Dr. Augustin.
Let me start with that. Thank you very much. WHO has been working hard to develop some of the guidelines, but not limited to support the youth initiatives. We have been working with so many groups, actually not only on NCDs, but also on mental health. I think some of them have seen them around here in this room. We have been promoting campaigns on mental health issues and NCDs in secondary schools. I think so far we still have an appointment on 7th on somewhere, Nikagarama, with one group of student association. So student association has been a very useful tool to make sure that we do an awareness. We make a certain age group to understand what is NCDs and what do we need them to do in order to fight against the NCDs. So at WHO, all these initiatives have been welcomed, and I think so far we have participated in many groups, and still having some of the requests from you, the Medical Student Association. We have Student Association of Psychological Student Association, Dental Student Association. So all these young generation initiatives, for us, we work very close to them, and we have been supporting them financially and technically to make sure that we move together on pushing the agenda of fighting or addressing the risk factors on the NCDs. So that's what actually the WHO have been engaged to promote and to support this young generation initiative. Thank you.
Thank you so much. Do you want maybe to add on that briefly?
Yeah, briefly, I totally agree. Our national response to non-communicable diseases in terms of prevention and related education has to be comprehensive and multi-sectoral, which means among the stakeholders, the youth, they have to play a key role. Yeah. And trying to push a bit back, the youth should not be waiting for the elders to tell them this is what we want from you. They can also propose. We have different platforms. I remember I've met some of the association from medical students. They had brilliant ideas, and they took that initiative to come and see us as a national program and say, look, this is what we can do together. So that behavior also, we need to keep strengthening it from the youth. Otherwise, from ourselves as the national program, I totally agree, we need to make sure they are part and parcel of the technical discussions that can inform policies we really want to have in our country. That's what I can add.
Thank you so much. Staying on that, what would you say, or how would you say that the work of RBC together with the Ministry of Agriculture is? How is your collaboration?
Yeah.
Referring to the question of...
Yes. On that One Health approach, I would say we have a specific team at RBC that is in charge of One Health, not only focusing on infectious diseases, but really tackling the One Health approach as a comprehensive package. Why do we choose to have it as a specific team? We chose to have it as a specific team to make sure they are really focusing on it, but also they are involving whoever is part of it. This is at the technical level. At the policy level, we have what is called One Health Coordination or Steering Committee that is really involving the top leaders from different sectors to discuss on issues related to One Health. So I can guarantee you whatever is discussed in that platform is not looking at specifically infectious diseases only. It is really a comprehensive discussion tackling all One Health related issues.
Yeah. Thank you so much. I hope you have enjoyed this panel discussion as I did. We've gone to the end of it. I'm going to give 30 seconds to each for one call of action. I know Professor Muchumbitsi already talked about the multi-sectoral collaboration and the alternative financing, but let me hear from WHO as well as RBC, one call of action as we are leaving this panel. Thank you. Okay, go ahead.
Yeah, I would focus on two points. One, we still need everyone's here contribution. We have data, we have evidence, then we have to move to the action, targeted action. Secondly, we need to move from modeled or estimated burden for us. We have to make sure we put in place systems or M&A system that have to give us our own estimates. Thank you.
I'm not sure that last point was very clear, but it's okay.
Monitoring and evaluation.
Exactly. That's also what I was hearing when he was saying that. Dr. Augustin, you have the floor.
Okay, thank you very much. The STEP survey findings actually is giving us where the platform where we are sitting now. So I think from WHO or other stakeholders, it's our high time to make sure that we see where we are, we modify or we review our strategies to make sure that the next evaluation, the third evaluation, they should be marked with a difference, a significant difference. Actually, this is the way we can always evaluate our efforts invested and see the way forward. So I think shortly I can say that.
Thank you so much. Luckily, WHO has the power to hold the government accountable. Thank you so much, guys. I really enjoyed this. Do you have something to say?
Yes, please. I'm sorry, but there's something I didn't mention. I know I talk about it every time, but integration should go beyond integration of NCD care, diagnosis, and control in the health facilities, but we should also think about optimizing the resources, the use of resources we have through integration between infectious diseases and NCDs. I know it is some of the things we have started discussing, but I'm happy to have my neighbor here on my right, who is in charge of that. When can we have a technical working group to discuss about this? How do we integrate HIV and NCDs, NCDs and TB, and NCDs and malaria, so that we can use the same resources to improve what we do? Thank you.
I am saving meaningful involvement of people living with NCDs. I'm saving targeted action. I'm saving alternative financing. And I'm also saving integration of NCDs and other infectious diseases. Thank you so much for participating into this panel. And thank you guys for also engaging with us up here. Yes, thank you so much. Let's clap.
Thank you so much.
After, right now? I'm requested for a group photo, so okay. Sitting or standing? All right.
On the stage.
NCD Technical Working Group. I think after following the presentations, after seeing the findings and the burdens of the NCDs, I hope everyone will be willing to be part of the National Technical Working Group for NCDs. So my presentation is very brief. It is a call to work together in a technical working group so we can address the NCDs. So you know that the NCDs are guided by, the response to NCDs is guided by the National Strategy for Transformation, the NST1, that span from 2017 to 2024, We have the health sector strategic plan for 2018 to 2024. We have the WHO roadmap and the SDGs. So the fight against NCDs is cross-cutting and multi-sectoral. And for that reason, the ministry is establishing a multidisciplinary team for the NCD TWG. And the technical working group will guide policy formulation, strategic plan development, the monitoring of progress of the implementation of policy and plans, and especially to identify challenges and formulate recommendations to attain country and global goals. The general objective is to provide forum for policy dialogue, strategic planning, resource mobilization, implementation, monitoring and evaluation of plans that will contribute to reduce NCDs related morbidity and mortality. As you have seen, the NCDs are challenges and we need to collectively address the challenges. The specific objectives is first to develop evidence-based NCDs national policy and strategic policies. The second is to assist in mobilizing resources that are crucial to implement the different programs. We need also to develop evidence-based NCDs national guidelines, protocols, job aids, and we need also to develop, but also to implement the NCD research agenda to inform our national policies. We need to build a strategic information, not relying only on surveillance systems. We need to put in place how we can collect quality data to inform the policy and the programming. We need also to build capacity of healthcare workers and program managers to address the NCDs. And we need to focus on the primary health facilities that need to receive the patient. We need also to remember the community annual report for HIV, for TB, for malaria, for maternal and child health, the academia, the Health Professional Association, the Health Insurance Association, the people living with NCDs, the representative of the media. The media are crucial in order to inform the community. We need civil society organization, national and international NGOs, and the private sector as well. We have already the chair of the technical working group, that will be Dr. Francois, the NCD division manager. We have two co-chairs, WHO, I will be co-chairing this technical working group, and the alternate co-chair will be from CHI, Clinton Health Access Initiative. The secretary will be elected by the members of the technical working group. So we are appealing to everyone, to all institutions listed above, to nominate staff to be part of the technical working group. Thank you very much.
Thank you so much, Dr. Gilles. Wonderful. Doctor, we have a question, and I think it's really urgent. We can give you a chance to. Can we get a mic?
And it is published, what should be the high-level NCDs coordination committee at a national level. Yes, this technical working group is effective and we are applaud for it, we are ready to be part of it, but which political power of decision would have this technical working group in terms of national policy, in terms of allocating resources? We would wish to have a working group, a committee of ministers who can talk to each other about the higher level of decision, because I don't see how this technical working group is going to speak about sharing resources or budgets or allocating budget to the NCDs. So could we maybe look at the possibility of having also that high-level committee? Because the social cluster so far doesn't include, as far as I know, all the stakeholders, ministers who should be in. It is social, but it's not, I don't think it has enough people in there. But what we have been discussing was that we could build on that social cluster to have a high-level coordination committee or mechanism, as they call it, on NCDs at the highest level of discussion. Thank you.
Wonderful. This is the power of civil societies when it comes to advocating. And yes, this recommendation, I'm pretty sure they will be taken into consideration. So far, this conversation are being actionable or political? Actionable? Yes? Political? Wonderful. So before we move maybe to the next item, maybe as another recommendation, we didn't see the Ministry of Internal Security or security organs, since we saw findings on trauma and disabilities as very alarming. So that could be also another recommendation. So as we move forward, please allow me to welcome Mr. Donatien Nagara. He is the Director of Monitoring and Evaluation at the Ministry of Health. He is going to actually talk about the way forward and key recommendations, considering about all these recommendations provided by members. He worked at the Ministry of Health, so I think he's in a good position to address all of this. Please welcome Mr. Donatien. Thank you.
Thank you very much. After this discussion, I think it's time to read the recommendations. Some of them have been captured in presentation, but this one we've been collecting them as we are moving toward the discussion and the comment from different people. So please feel free where you think we didn't capture well the recommendation. Feel free to correct us so that we can put them in the right way and starting maybe thinking about how to implement them. So some comes from the talking point from the minister, others coming from the panel discussion and from question, as I said before. So we have a couple of recommendations, almost 15 or 12. The first one is to conduct subsequent analysis from the findings of this survey, which we think can be implemented, if possible, by end of next fiscal year. Another one was to establish strong collaborations with partners to reduce trauma cases. That has been raised by, I think, Madame Irene. Another one was to reinforce law and interventions to reduce tobacco consumptions across country, but with more emphasis on province with high prevalence. As we saw that we have some provinces with high prevalence of consumption of tobacco. Another one is on translating the Rwanda NCD risk factors survey findings into actions. That was captured, I think, in one of the recommendations. And please feel free for the timelines we think that is not realistic, we can adjust them. Another one was to enhance accessibility to screening and the early diagnosis of cancer at all levels and ages, because we found also that we have cases of cancer for some group ages which really are not old or advanced ages. So this also to think about those group age for screening by availing really trained workforce and the diagnostic equipment and resources, because we found that it's not only aspect of resources, workforce, but also resources and equipment are also needed for screening. Another one is on to reinforce the use of trauma registry in all hospitals. That was from I think, Madam Irene. Another recommendation is also to consider the scale-up of prostate screening, not only other screenings, but also considering also prostate screening countrywide, including also awareness and awareness for the screening. Recommendation number 9 is to conduct an assessment to know the causes of high number of assaults among children. Another recommendation was to enhance data availability and data use through system interoperability. Another one is to provide continuous support. That one I think can be corrected from a representative for WHO, to provide continuous support to RBC divisions on all aspects related to NCDs. This one comes from the 12th one comes from Professor Mchumbitsi. It's to advocate for a formal high-level multi-sectoral coordination committee to discuss on NCD policy actions and challenges. I think this is really very, very important recommendation, and it has also been captured when we've been doing dissemination in NCD, step survey in provinces, to have really high-level forum where we can discuss also aspects related to NCD. So this one, if it can be well captured, that will be really very helpful. Recommendation 13 is to advocate for more inclusiveness of youth in NCD-related technical discussion. This one also a very high-level recommendation. If we can rephrase it well and to set the timeline, that will be helpful. Recommendation 14 is to reinforce the use of routine data instead of NCDs estimates. We've been seeing in many surveys that people are starting now saying, hey guys, because we have routine data of good quality, I think we should rely on these data and not only waiting 5 years or many years to do some kind of retrospective studies to get the prevalence of a disease. So this is really an opportunity to see how we can reinforce our routine data to use them for at least continuous or timely decision making. Another one is to call for optimization in the use of resources from all programs. That also is very important because now systems are real horizontal. We are not into vertical way of doing healthcare. I think uses resources from different programs is also very important as far as NCD is concerned. So these are the few recommendations we have captured for this discussion. But again, where necessarily, please feel free to correct so that we can input it in the program, in the report. Thank you very much.
Thank you very much. I captured that where necessary, please do recommend to include. So, okay, before we continue, can you please provide a mic? Maybe she has a question.
Thank you much for the recommendation. As I've seen all the recommendation, they are looking at the disease, but they are not looking at a person. I haven't seen a person in those recommendations. I think what I mean is that we should look at a person holistically, and we should not be treating a disease, but we should be treating a person. So where does a person come in those recommendations? I haven't seen the continuum of care of a person, because why I'm saying so, we are doing very well in screening. But after screening, we do we do what we call breaking the bad news. I have a cancer. And as Professor has said, even this 10% to go for treatment is very hard for some people. Even for Lamar, if they ask 15%, it's not easy for that person to access the treatment. So which recommendation among those is looking at a person holistically? First, we are looking at the physical, by the way. We are not looking at psychosocial. We are not looking at spiritual. We are not looking at even at how a person, from the navigator from the health center to the community. Do we usually go to the community to see that person? Because why I'm saying so, we said about NCD integration in HIV. I worked in HIV for a long time, but we had that of even going to see that person who has been diagnosed with HIV. How is that person? How is the adherence to the treatment? How is the family? I haven't seen the family and the person in this recommendation. So can we get one recommendation for looking at a person, but not looking at a disease? Thank you.
Right. I think they are noting. We need to engage also patient groups or people living with NCDs. I'm pretty sure they are noting that. So moving forward, we are almost getting to the end of our agenda, but before that, I would like to call on stage Dr. Albert Tushim, who is the head of HIV disease prevention and control department at RBC, for the closing remarks. Please welcome Dr. Albert.
Thank you very much. Mine, it won't be long, just to thank everyone here. First of all, for making time to join us today. This effort, it's a joint effort. It's not a Ministry of Health effort. It's not an RBC effort. We really recognize everyone's contribution. So for that, we thank you very much. Secondly, if you look at what we had today and what we had 9 years ago, or 8 years, 10, we've made some progress. Also, that progress is because of everyone's here contribution. So we still need you, so that by the time we go for the next one, which is not going to be in the next 10 years, I believe, we would be able to see more progress. So we've seen where we have to focus. We've seen where we should be investing. We've got ideas during the discussions. So let's move to action. Lastly, I would like to thank the team that has put everything today so that we can have this wonderful event. But again, it has not to stay here, or we don't have to stop at this point. The main and most important effort is what we are going to do after here. How are we going to operationalize the TWG? How are we going to move from the discussions within the TWG to the multi-sectoral platform that is going to help us put in place policies? How are we going to make sure those policies, they are really people-centered, as it was raised?
So that's where we need to focus. And that's where we need everyone's contribution. And that's where we need most of our resources. So with this, I thank you very much on behalf of the DGRBC, who was really keen to be with us, but also on behalf of our minister who had to join other meetings. So I thank you very much, and yeah, tukunje amashati ubundi dukore. Murakoze.
Yes, for the last word he just meant, let's get to work, and this is what is expected after these findings, and really one of the outcomes was to enhance, collaborations and to inform policy making and strategic planning. So we expect more actions from these findings. Ladies and gentlemen, we have come to an end. I think we kept time, despite that we started a bit late. Wonderful job to everyone who presented, and for all of you guys for attending and contributing to this agenda. So before we proceed to lunchtime, please welcome on stage for a group photo. As you can see, it's on it's the last item on the agenda. Last item is lunch, but please proceed forward for a group photo. I thank you all for your participation today. Thank you. The photographers can advise us where we can stand, but I think it's here in the front. Please proceed for a group photo.